In this section, we are going to solely discuss on the management of hyponatremia. In the previous video itself, I have given a glimpse on how to manage a hyponatremia as an overall basis, like how to correct a hyponatremia in a crude way. But this video is all about fine-tuning your knowledge in exact correction of hyponatremia. And that is really, really important because precise correction will yield you good prognosis. At the same time, they will avoid you from getting into negligent activities like developing osmotic demyelination syndrome. So remember, one of the very important things to know even before starting the correction of hyponatremia is the fact that overcorrection will lead to ODS, osmotic demyelination, and everyone knows that, and you don't know the importance of that. That's why. So if you are going to exceed the cutoff, you will result in ODS, and which can be, in fact, irreversible in many patients. So patient coming to you for simple correction of hyponatremia and going out of the hospital in a wheelchair or a stretcher is something unforgivable and it's a sin. So that's why you should be very, very clear in not to overcorrect hyponatremia. Let it be like that. Don't worry about that. So even if the sodium doesn't improve, but do not overcorrect it. That's the take-home point. Because we are violating the basic Hippocratic oath, that is do no harm. Primum non nocere. So do that first. So do not overcorrect. Again, a warning. So because I have encountered a lot of cases with ODS, even the clinicians do not even agree that they have overcorrected the sodium and they try to keep on telling some excuses for that it's not their fault. So it is your fault, accept it. You should not do that in the first place. So it is something like a preventable disease. So that's what I'm going to tell first. What are the risk factors for developing ODS? And the number one risk factor is going to be your overcorrection. So at what cutoff you are likely to induce an osmotic demyelination? Remember, when you exceed this cutoff of 10 to milliequivalents per liter per day correction, which means per 24 hours, if you exceed the correction of sodium in the serum beyond this rate, you're going to have a high risk of developing osmotic demyelination. And remember, this is carrying the highest risk. It's always that per day risk that carries the highest risk, not like per hour or half an hour, not that. So even there are instances where the correction has been to 15, 16 milliequivalents per day accidentally. I mean, in 3 hours or 6 hours, they have corrected to 15, 16. But again, within a day, they have relowered the sodium to less than 8, that particular cutoff, so that they have not resulted in ODS, which means it's always about that per day correction in the entire 24 hours. That's going to make a lot of sense than that sudden overcorrection of within 6 hours or 4 hours. That's very, very important point. Even if you overcorrect within 6-7 hours, like 8-9 milliequivalents, again, you have a lot of time. The next 15 hours are there so that you can relower back and you can reduce the risk of ODS. So that per day again, very, very important. Then, if you are going to exceed 18 milliequivalents per liter correction over a period of 48 hours, if you exceed this cutoff again, you are having a high risk of ODS, but again, this is going to be the most important number for you. Okay. So how can you avoid this ODS? It's simple. So these are the risk factors for developing ODS, and how can you avoid ODS is by limiting the rate of correction of serum sodium. So what should be the rate of correction? According to most guidelines in acute hyponatremia, the rate of correction should be less than 10 to 12 milliequivalents per liter per day. And in a case of chronic hyponatremia, the rate of correction should be less than 4 to 6 milliequivalents per liter per day. So this is according to many standard guidelines. But there was an article in NEJM which came last year because many clinicians will not be able to find out whether it's really an acute hyponatremia or chronic hyponatremia at the time. So they need an overall cutoff, which will be beneficial for everyone to understand easily, though clearly it's been mentioned on gold standard number, that is less than 8 milliequivalents per liter per day, which means the current number is 8 milliequivalents and you can correct up to 8 milliequivalents. Don't exceed that. Maybe less than that is also not so having clinical importance. So you can keep a cutoff of 8 milliequivalents. So if you want one standard number, remember this 8. Up to 8 you can reduce the serum sodium in a period of 24 hours. So very, very important. Again, 48-hour mark, do not exceed this 18. Again, that's a very important number. Okay, fine. So now you know you should not exceed this cutoff. So now we are keeping a magical number 8. 8 is what I'm going to correct in a particular day. So after knowing this, let us move on to the actual treatment in acute setting or emergency setting. How will you manage a hyponatremic patient? So whenever a patient is coming with a low serum sodium and it's a hypoosmolar hyponatremia, I've ruled out hyperosmolar type and normoosmolar type because they are false hyponatremia. So it's a true hyponatremia. And you're dealing with a true hyponatremia means see whether it's an acute or chronic hyponatremia. That's the first step, number one step. Again, I'm repeating the definition of acute and chronic. Acute hyponatremia means those hyponatremias that develop within a period of 24 to 48 hours. And chronic hyponatremias are the ones that develop over a period of more than 48 hours. And if you don't know the duration of hyponatremia itself, by default, that becomes a chronic hyponatremia only, because you should not take any risk. Whenever the patient is having acute hyponatremias, you have to know whether the patient is symptomatic or patient is asymptomatic. Even before that, you have to know whether the patient is having a serum sodium of less than 130 or the serum sodium of more than 130. Remember, if the serum sodium is more than 130, you do not give any treatment, just observe the patient. That's more than enough. And obviously, if possible, you can give some corrective measures, additional corrective measures, which I told you already. Whenever in this entire lecture, if I use the word corrective measure, it means if, depending on the volume status, if you have a hypovolemic hyponatremia, you are going to use isotonic normal saline. If you have a euvolemic or a hypervolemic hyponatremia, the most important is the fluid restriction. So this is going to be the important corrective measure which I'm going to talk about. So which I'm not going to repeat again and again. So you have to ensure and emphasize yourself that this is the corrective measure. That's all. And a lot of other corrective measures which we have discussed already in SADH, we have already discussed in diabetes insipidus, and we have discussed already in detail in the previous video also. So I'm not going to emphasize on the corrective measures anymore. I'm just going to emphasize on the acute treatment of hyponatremia. That's all. The sodium is less than 130 and it's acute. Acute are more dangerous in developing the symptoms. Clear? So because anything that is acute to the body will not tolerate that easily. So it's an acute hyponatremia less than 130 means see whether the patient is symptomatic or not. Now I can tell whether the patient is asymptomatic or the patient is symptomatic. The patient is symptomatic, what I have to do is immediately you have to give a 3% NaCl, that is hypertonic saline, because here the treatment becomes urgent. Because less than 130 acute development of hyponatremia, definitely treatment must be urgent only. And 3% NaCl you should be giving over 10 to 20 minutes. And the dose you will be giving is 100 ml. And wait for the improvement. So suppose if you see this improvement, what do you mean by improvement? You will be having improvement in the neurological symptoms, because symptoms in hyponatremia means we are talking about neurological symptoms only. We are looking for the improvement in the neurological symptoms. If the improvement doesn't happen, then you can repeat into 2 more boluses, which means total you can give up to 3 boluses. That's the indication right now. If there is a good improvement, you can stop giving boluses at that point itself. There is no need. Stop giving bolus at that point and start applying the corrective measures. Plus or minus corrective measures. That's what you're going to give. So clear? So how will you give 3% NaCl? First you are given 100 ml. Look for the improvement. No improvement. Give another 100 ml. Look for improvement. And again no improvement. Give another third 100 ml. Suppose even after giving the third 100 ml, if the patient still has not improved from the symptoms and still the patient's neurological symptoms are continuing even after 3 bolus of 100 ml, 3% NaCl, it means then you are unnecessarily wasting time on thinking that the cause of the neurological symptoms is hyponatremia. It may not be the hyponatremia that is causing neurological symptoms. It could be something else like stroke or some other, de novo neurological disease that is causing the neurological problem. So that is the reason why the guidelines are telling do not waste time on sodium, thinking about hyponatremia as a cause of neurological symptoms after giving 3 bolus of 3% NaCl and the patient is not improving. So stop there. 3 bolus are the indications. So why we are giving this 3 boluses? Why we are giving this urgent treatment in the first place? Why you need this urgent treatment? Whenever you use this urgent treatment means you are using this hypertonic saline means you are trying to improve the patient's symptoms as soon as possible and the patient's risk of brain herniation, all these things you are reducing immediately. So it's been proven by multiple trials, just raising the serum sodium to 4 to 6 milliequivalents as soon as possible in no time, even in half an hour or 1 hour, makes a lot of sense. It can rapidly reduce the risk of neurological deterioration. At the same time, they can rapidly reduce the risk of brain herniation also. That's why in all the urgent scenarios, you give 3% NaCl. And that is to just raise the sodium to 4 to 6 milliequivalents per liter as soon as possible. But wait. You might ask me, sir, you only told that sometime back you should not exceed this 8 milliequivalents per liter per day cutoff. Suppose if I am increasing to 4 to 6 milliequivalents in no time, you told it ASAP, which means if I am increasing to this value within some half an hour or 1 hour, will I be having the risk of ODS? Actually, no. I clearly told you the risk of ODS is only when you exceed this cutoff over a 24-hour period, not like half an hour or 1 hour. So even when you have raised the serum sodium to 4 to 6 milliequivalents per liter in half an hour or 1 hour, it's not a problem at all. You can just stop the correction there and you can wait and you can just slowly rise to ensure that the serum sodium does not rise to that more than 8 within the next 24-hour mark. So it's not a problem. Acutely, you can rise 4 to 6 even within half an hour or 1 hour, not a problem at all, but make sure you don't exceed that 8 cutoff over a period of 24 hours. Even if you have exceeded the cutoff, like 8 or 9 you have inherently increased within a period of 2-3 hours, again it's not a problem. You are doing at the good intention of the patient to reduce the risk of neurological deterioration. So not a problem. Only after 24 hours it's a risk. So again you can re-lower the sodium by giving a lot of interventions which we'll discuss in later on. So acutely rising that 4 to 6 should not be a problem for you. So that is to prevent that further neurological deterioration. Be very clear about that. So how you are going to handle a chronic hyponatremia? Whenever you are dealing with a chronic hyponatremia, see again where the sodium is more than 130 or the sodium is less than 130. The sodium is more than 130, no need to do anything, just observe the patient and you can give corrective measures, corrective actions depending on the volume status, which you have discussed already. The sodium is less than 130, see where the patient is having severe symptoms. Severe symptoms, here I mean by only two, that is coma and seizures, or at least an altered mental status. If the patient is having severe symptoms, or if the patient is a patient of known intracranial pathology, which means already the patient is having some tumor in the brain or recent brain surgery, they are at high risk of herniation, that's why. So answer is yes or answer is no. If answer is yes, which means patient is actively seizing or throwing seizures, or patient is having is a known case of having intracranial pathology or brain pathology, in these patients again the treatment becomes urgent treatment, which means you are going to give 3% NaCl, 100 ml over 10 to 20 minutes, and you can give up to 3 boluses. And again, I'm telling 3 boluses is not mandatory. Depending on the improvement, you can give maximum of 3 boluses. That's what I'm trying to tell. Plus, at the same time, I will be attempting corrective measures also. So, because I have to correct the underlying cause. So, corrective actions also I can take. Suppose the patient is not having any severe symptoms or not having intracranial pathology which means here the patient is asymptomatic or patient is having only mild to moderate symptoms of hyponatremia. In this condition, see the serum sodium value, whether it is less than 120 or more than 120, that is in the range of 120 to 129. The patient's sodium is 120 to 129, just again you need not do anything, just observe the patient. At the same time, you have to give corrective measures to raise the sodium to more than 130, safe value. The serum sodium is less than 120. In this situation, here the patient is not at very high risk, not at very low risk also, because serum sodium is very, very low, severe hyponatremia. But since it's chronic, patient would have adapted, that's why he's not having that severe symptoms. But at the same time, they might throw seizures or they might go for severe symptoms at any point. So it's not like very high risk, not at very low risk. So you can give 3% NaCl, but not on an urgent basis. You can give at a rate of 15 to 30 ml per hour as a constant infusion in these patients. Not urgent, it's a non-urgent basis. At the same time, you can give other corrective actions also based on the underlying cause of hyponatremia. So this is how you are going to manage a patient with a hyponatremia in the acute setting or the emergency setting. Very, very, very important again. So next you have to know what are the patients who are at risk of overshoot, because you are giving a lot of corrective actions, and you also have to know what are the patients who are at risk of overshoot and what will you do for them. there are almost 2 to 3 group of patients who are at risk of overshoot. The first group of patients are hypovolemic hyponatremia patients. We have discussed innumerable times. In the last video also I explained this in a very detailed way. Why hypovolemic hyponatremia patients are at risk? Because when you start correcting the volume status, the ADH response will become nullified and immediately you will start losing water relatively more and the sodium rise may be very rapid. So that's why hypovolemic hyponatremia patients are at very high risk of rapid overcorrection and overshoot. Second, patients who are having SAADH, patients who are having hypocortisolism, that is secondary adrenal insufficiency. These are rapidly reversible causes. That's why SAADH is usually due to some underlying cause. For example, some infection, you give antibiotic, immediately the SAADH will improve and the patient will start correcting sodium very, very fast. And adrenal insufficiency, again, if you give hydrocortisone, patient will improve dramatically. And hypothyroidism, give thyroxine, patient will improve dramatically. So there are a lot of areas where the patient might improve very, very fast. So be very careful in these situations. So in these situations where patients are at risk of overshoot, so try to maintain sodium correction at less than 8 milliequivalents per liter per day. So how can you do that? You can easily do that by giving prophylactic desmopressin. So these patients you can use prophylactic desmopressin, that is DDAPP, 1 to 2 microgram every 6 to 8 hourly. You can give IV. At the same time, you can even use a dextrose 5 water, but that is not needed. Just a prophylactic desmopressin is more than enough. And many practitioners do advocate this prophylactic desmopressin to these patients. Because in hypovolemic hyponatremia, I've never seen such a rapid correction. One lady, 63 years, I think she has developed a diarrhea and she came with a severe volume loss and her sodium was only 112 or 113 at that point of time. The ER resident just gave 2 bolus of NS and they gave a maintenance of 100 ml per infusion of normal saline. By the time she reached the ICU, and the next day morning they are seeing the sodium. Night she got admitted at 12 o'clock. Next day morning 6 a.m. the sodium was 134 from a value of 112, 22 in a period of 6 hours. That is very, very likely with hypovolemic hyponatremia. There can be rapid correction. So that is why immediately what I did is I reloaded the sodium by giving desmopressin and I stopped all the normal saline and it really worked. And the patient improved and luckily didn't develop any osmotic demyelination syndrome. So it's a dreaded complication. So be very sure about that. So these are the patients who are, at risk of developing ODS, maximum risk of overshoot. And then we can also have to know what will you do when the patient has actually overshooted. These are only risk of overshoot, but now I'm telling second branching from here. So what if the patient has actually overshooted? Now overshoot has actually happened. Overshooted already. It exceeded 8, 10, 12 or even 15 like what I told. So what you are going to do in these patients? So see whether the patient has developed ODS already or the patient has not developed ODS. So signs and symptoms of ODS. So if the patient has no signs and symptoms of ODS or no evidence of ODS, in this condition, correct with desmopressin and dextrose 5 water and relower serum sodium to maintain correction at less than 8 milliequivalents per liter per day. So aim for correction is you have to maintain at less than 8 milliequivalents per liter per day, and this is absolutely okay. So even if you accidentally overshoot in a period of 3-4 hours, you still have a time up to 24 hours, so you can relower the sodium and bring to less than 8 and maintain at 6 or 7 milliequivalents throughout the next 24 hours. Not a problem. The patient had shown signs and symptoms of ODS. Here now actually the life of the patient matters a lot because ODS will result in irreversible neurological damage. So without wasting any more time, you have to relower the serum sodium to a very great value like 16 milliequivalents per liter. You have to relower immediately and it has to be done ASAP. And you will be definitely doing with the help of desmopressin and dextrose 5 water and stop all the sodium correcting agents. Whatever corrective measures you are giving for sodium, immediately you have to stop. So don't give any corrective measures for hyponatremia, just relower the sodium to almost 16 milliequivalents per liter in no time, within like 3-4 hours, you can relower the sodium and maintain the sodium in that range because patient has already developed ODS. And relowering the sodium has been associated with improvement in the neurological outcome. Some patients has completely reversed back to normal also. So that is the reason why this relowering of the sodium is very, very important if the patient has started developing signs and symptoms of osmotic demyelination. So this is what you have to do whenever the patient has accidentally overshooted. So now with this, we also discuss on some of the important points on osmotic demyelination syndrome. So remember, osmotic demyelination, even though you can call acute hypernatremia can cause osmotic demyelination, but I don't believe in all those things. It's always almost iatrogenic due to rapid overcorrection of sodium. And it's a dreaded complication because the patient may go for a locked-in state. Let us see what will be the clinical features. Clinical features, patient will go for a quadriplegia because of pontine demyelination. Remember, this ODS previously called as central pontine myelolysis. This is an old name. Now currently we don't use this name, we only use the term called ODS because the demyelination doesn't only happen in the pons, it happens in many extrapontine centers and even in the spinal cord. It's been proven. That's why they renamed it to ODS. It's not a correct name, CPM, that's why. And this quadriplegia is spastic obviously because it's a human lesion, pontine myelolysis. Then they can develop coma, stupor, obtundation. They can develop catatonia, tremors, extrapyramidal symptoms. And they can also develop a lot of behavioral changes with them and subcortical dementias. A lot of things are possible. Clear? And finally, ultimately, if the syndrome is very severe, they can even go for locked-in state. I mean, I don't know how many of you have heard about this locked-in state, but we will be discussing about the locked-in state in CNS section in detail. But right now, you have to understand that locked-in state means a character you see in Munna Bhai MBBS movie, like that Anand sir who goes in a wheelchair all the time. So that's a locked-in state. So you can imagine a scenario like that, which is absolutely, that's what I'm telling you, this is a sinful condition if you introduce this into the patient. So the patient may develop even bulbar paralysis, dysphagia, dysarthria, so many problems. Clear? And remember, the clinical features may not develop immediately, may take up to 2 to 6 days to develop. So it may not develop immediately. So that's why, like once you get it, it's very dreadful. It may not reverse completely. So be very careful. And investigation wise, you don't have much investigation options. Only the demyelinating lesions can be proved with MRI. Obviously with contrast we will do usually. So again, MRI is not reliable in clinical settings because the findings may take up to 2 to 4 weeks to develop. So you cannot wait for 4 weeks to confirm ODS and relower the sodium. You have to, based on clinical findings itself, you have to relower the sodium immediately. So that's a very important aspect again. So let me show you one important MRI that might be asked in your exams. So this is a case of ODS where this is a normal MRI initially where they develop this pontine demyelination after this overcorrection of sodium. So again, be careful. So this is the MRI that you have to know about the CPM, central pontine myelolysis or osmotic demyelination syndrome. So what are the risk factors for developing ODS? The first risk factor is always rapid correction. That's all. That's the most important risk factors. But there are some other risk factors that make the patient that prone for osmotic demyelination syndrome. So usually I give a mnemonic called HARM. And remember, especially when you exceed the per day cutoff. Exceeding per day cutoff is really a very high risk. So what are the HARM mnemonics? So H stands for hypokalemia. And the patient is having associated hypokalemia, it's a very high risk. I'll tell you why hypokalemia is a risk, because correction in the presence of hypokalemia will correct the sodium very rapidly. There are a lot of reasons are there. Because even though I have told you the formula, that is serum sodium is an approximation of total body sodium by total body water. This is not the exact thing, because this is just, I told you, even I'm not contradicting my statement, this is just to make you understand things better. But usually there is something called a classic Edelman equation, where he told like serum sodium is an approximation of total exchangeable cations in the body, which includes even potassium. Clear? So which means even if potassium is rising, serum sodium will rise very rapidly. So which means in the presence of hypokalemia, if you give potassium infusion, sodium will rise very rapidly. I have seen a lot of patients, you go to the ICU patients and patient will be having hypokalemia and patient might be having normal sodium. When you start correcting the hypokalemia, the patient's sodium will start improving. And so even they might enter into a hypernatremic range. I don't know how many of you have noted this. Many times I have stopped the potassium infusions. Potassium and sodium both will correct automatically. So I've done that. So that's what I'm trying to tell. So there are a lot of things you have to know to understand this. At the same time, why increasing the total body potassium? Because potassium, I told you, is as osmotic as sodium, but its only thing is it's present in the intracellular region. That's all. So suppose if you are having a hypokalemia and you are correcting the potassium, you are giving a lot of potassium to the patient. So what will happen? Obviously, the normal location of this potassium is intracellular region. Because of the activity of the sodium potassium ATPase, they are bound to move into the intracellular area. So now this potassium, I told you, is as osmotically active as sodium. So by moving, it also takes a lot of water along with that to the interior of the cell. When they take water into the cell, outside ECF now will have less water, and obviously it will result in low water in the ECF, means they will raise the serum sodium very rapidly. So you have to be very careful about this. So hypokalemia is a very important risk factor for developing rapid rise in serum sodium and development of ODS. That's the reason. And patients who are having hepatic disease, especially severe hepatic disease, that's another H, severe hepatic disease, chronic or acute, doesn't matter. And alcoholism, high risk, chronic alcoholism, and conditions that go for rapid autocorrection. So you know what are the conditions that go for rapid autocorrection? One important condition that goes for rapid autocorrection is your hypovolemic hyponatremia, then patients who are having SCADH, then patients who are having adrenal insufficiency, patients who are having hypothyroidism. All these patients are prone for rapid autocorrection. So you have to remember that also. Because once you treat the underlying cause itself, they will autocorrect rapidly. You need not give any sodium infusions or other corrective measures. M stands for malnutrition. So these are very, very important risk factors for developing hyponatremia. And number 3, very severe hyponatremia. Very severe hyponatremia means if the serum sodium values are less than 105, such a severe hyponatremic patient, again they are at very high risk of developing osmotic demyelination syndrome. So treatment wise, ODS, again you have to re-lower the serum sodium by giving desmopressin and dextrose 5 water. How much you have to re-lower? To approximately 16 milliequivalents per liter sodium in the serum value as soon as possible. That's the idea. So this is how you remember osmotic demyelination syndrome, and this is a very, very important image that you have to know for exams. This is how you have overshooted. Okay. In patients, I mean, because I told you that fact, I forgot that to tell one thing in the flow chart. So these patients who are asymptomatic, we have not seen at all, isn't it? So these patients are having less than 130, acute hyponatremia, but they are asymptomatic. How will you treat them? So now you have to see, is there any evidence of autocorrection, ongoing autocorrection? Autocorrection usually happens by water loss, because body tries to autocorrect the low serum sodium by losing the water, because when you lose water, sodium concentration will improve. So what are the evidences of autocorrection? First evidence of autocorrection is that the patient will be having urine osmolality of less than 200, obviously, which means the patient is losing water and autocorrecting themselves. And second, if the specific gravity is less than 1.005, which means its urine is nothing, just water. Less than, it's 1 means 1 is a specific gravity of water. Very dilute urine, which means they are trying to autocorrect themselves. And if the urine cation ratio to the serum cation ratio, that is sodium, is less than 0.5. This we have already seen in SCADH chapter where, this ratio we use for how much amount of fluid correction we have to give, fluid restriction we have to give. So in this patients, they are already autocorrecting. That's what it means. Clear if it's less than 0.5. So if there is any evidence of ongoing autocorrection, yes means you can just observe the patient, no need to do anything, because they will autocorrect in a certain period of time. If there is no autocorrection in these patients, which means serum sodium is less than 130, acute hyponatremia, little high risk, and the serum sodium is less than 130 also, not a mild hyponatremia, and the patient has no evidence of autocorrection also and asymptomatic, means no need to treat very urgently or no need to treat less urgently also. Just give 50 ml of 3% NaCl bolus, that is given to prevent the further fall in serum sodium, plus at the same time you can take some corrective action. That's all. Plus you can take some corrective action. So this is the flowchart that is complete now. So now we have seen what are the patients who are at risk of overshoot, and we have seen if you have overshooted, what you are planning to do. So all these things we have discussed already. So now let us move on to the correction formulas. So there are some formulas that predict the correction and the rise in the serum sodium. What are the formulas? And the first formula, what you have to know is on the sodium deficit. Sodium deficit means we are talking about the total body sodium deficit and not the serum sodium deficit. It's given by the formula called total body water multiplied by desired sodium, which means what is the sodium you are aspiring to get minus the actual serum sodium. So this is the formula. So again here the total body water is something important now because it varies according to the age. For example, in children and adult men, it will be 60% of the body weight. Whereas in elderly men and in women, it's 50% of the body weight. And whereas in elderly women, it is just 45% of the body weight. So again, it depends on the age. So I have to be very careful. Suppose let me give you a example problem. This problem we have already discussed the same values in SADH topic also. So let me tell a patient is suffering from a hyponatremia with a sodium of 110 milliequivalents per liter, and the diagnosis is likely to be SADH, and this patient is having a fixed urine osmolality of 308 milliequivalents per liter. It's higher than the plasma osmolality, but still it's fixed at 308. So that's one of the characteristic feature of SADH which you have discussed already. And this patient is a 65-year-old man and his weight is 60 kilogram. Clear? So definitely this patient is a elderly man. So which means his total body water must be 50% of 60 kilogram, that is 30 liters. That is the total body water. So according to this formula, if you want to calculate the sodium deficit, the total body sodium deficit, it will be desired sodium. So desired sodium, it depends on what sodium I aspire for. Let us assume I am aspiring to correct 8 milliequivalents in the next 24 hours, which means my desired sodium will be 118 minus 110, which means that is what I'm aspiring to correct in the next 24 hours. Multiply by total body water, that is 30 liters. So here I'll be getting 8 multiplied by 30. This is the value I'm trying to correct over the next 24 hours. So it will be 240 milliequivalents. So this is the sodium deficit with this desired sodium. Clear? So what fluids can be used to give this much amount of sodium? Any sodium containing fluid can be used, but you have to know how to calculate how much fluid needed. And again, we are talking only about the math. Please be very clear about that. We are not actually reflecting exactly what's happening inside your system. So it's only the math. We are correct. We are doing it right now. So for example, if I'm using 3% NaCl, that is hypertonic saline, to correct the entire 240 milliequivalents, so how much 3% NaCl I'll be needing? So you know 1 liter of 3% NaCl will contain 513 milliequivalents of sodium, or 514 according to some textbooks. Now 513 milliequivalents of sodium is there. So I can also write 1000 ml will contain approximately, so don't tell accurately, 500 milliequivalents, right? Approximately. I'm a doctor. I'd like to approximate everything. So which means 1 milliequivalent of sodium will be present in 2 ml, that's 1000 by 500, 2 ml of 3% NaCl. So I need 2 ml for every 1 milliequivalent. Suppose if I am planning to correct this 240 milliequivalents with 3% NaCl only, we know the derivation. 1 milliequivalent of sodium is equivalent to 2 ml of 3% NaCl, which means if I need 240 milliequivalents, then just multiply by 2, you will be getting 480 mLs of 3% NaCl. I'll be needing to correct this 240 milliequivalents of total body sodium. Similarly, if my fluid of choice is 0.9% isotonic saline, you know 1 liter will be containing 154 milliequivalents of sodium in isotonic saline. So 1000 ml, I can equate it to somewhere around 150 milliequivalents. So which means if I need 1 milliequivalent to be given via isotonic saline, the 1000 divided by 150 will be 6.6666. So I can write 6.5 ml of isotonic saline needed to correct 1 milliequivalent of sodium. To give 1 milliequivalent of sodium. So if I'm using isotonic saline for my correction. So now my idea will be very simple. I have to multiply by 6.5, which will be approximately 1660 ml of isotonic saline needed to give this 240 milliequivalents of sodium. This is only to infuse this much amount of sodium. This will not reflect how much you are going to correct. That's very important again. This will only tell you how much sodium you are giving through a particular solution. This will not reflect how much sodium will be corrected in the serum. So this is not going to reflect the magnitude of change of the serum sodium in the body. Very, very important. So don't take these formulas as Bible. Number 2, there's another formula, so where you can find out the change in the serum sodium, which means how much serum sodium changes can be given by the formula infusate. Infusate means the infusing solution. Infusate sodium plus potassium minus the serum sodium divided by total body water plus 1. Clear? So according to this formula, if I'm using 1 liter of 3% NaCl for that patient, what will be the magnitude of serum sodium change? What will be the change in the serum sodium? So you know 1 liter is going to contain 513 milliequivalents of sodium, which means infused sodium is 513 minus serum sodium is 110. We know that already. Here the infused does not contain potassium. Hypertonic saline does not contain any potassium in it. Divided by total body water plus 1 is here, it is 30 plus 1 is 31. So the net answer will be 403 divided by 31. I will be getting around 13 milliequivalents is the change in the serum sodium. So this is the magnitude of change I am expecting, that is 13 milliequivalents per liter of serum sodium must rise. Which means what I'm meaning is if I'm giving 1 liter of 3% NaCl, according to this formula, sodium will rise from 110 to 123. 13 is going to rise. Okay. Third formula also tells if you give 1 ml per kilogram of 3% NaCl, I'm going to result in rise of 1 milliequivalents per liter of serum sodium. Clear? So which means in this patient, if I give 60 ml of 3% NaCl, his serum sodium will rise from 110 to 111, which means I'm giving 1 ml per kilogram because it's a 60 kilogram patient. Suppose by this formula, if I'm using 1 liter of hypertonic saline, 1 liter of 3% NaCl, what will be the magnitude of change of serum sodium? So which means if I'm giving 1000 ml, I told you 1 ml per kilogram will rise. 1 ml per, this is the base, 1 ml per kilogram is going to rise 1 milliequivalent of serum sodium, but in this patient it's 60 ml, that will rise 1 milliequivalent per liter of serum sodium. 1 milliequivalent will be the change in the serum sodium. So if you want to know for 1000 ml, so I can write 1000 divided by 60 will be the magnitude of change, which means they are going to change by 17 milliequivalents. 16.66 will be the answer, so I am taking as 17. So according to this formula, if I am going to give 1 liter of 3% NaCl, my sodium will rise from 110 to 127. So this is going to be the magnitude of change according to this formula. But let us see how this formula is going to be a joke now. So these formulas are very poor in predicting the magnitude of true rise in the serum sodium in the body. Why they are very poor? Let us see. I already told you this patient is suffering from SAADH with a fixed urine osmolality of 308. Let us see now. So let me assume I am giving 1 liter of 3% NaCl in a patient who is having a fixed urine osmolality of 308 milliequivalents per liter, and again who is having a serum sodium of 110, a male with a body weight of 60 kilogram and 65-year-old man. So the same thing I'm rewriting. So you know 1 liter of 3% NaCl will contain 513 milliequivalents of sodium in total in the solution. Now, if I'm going to give this 500 milliequivalents of sodium to a patient who is suffering from SAADH with a fixed urine osmolality of 308, so why SADH because I know the patient will be euvolemic. The most important characteristic of a euvolemic patient is total body sodium must be normal. To have total body sodium to be in the normal range, you should have a sodium input into the system must be equal to the sodium loss from the system. Then only they can be euvolemic and the total body sodium will be normal. Then only you can diagnose SADH in the first place, which means if I give this 513, everything will be lost in the urine, which means input will be equal to the loss, which means all 513 will be lost in the urine. But how much urine is needed to excrete this 513 ml? Remember, they are excreting at a lesser osmolar range compared to what your infusing solution is. So which means to eliminate this 513 milliequivalents of sodium at a urine osmolarity of 308 milliequivalents per liter, they need 1.65 liters approximately. That is 1.66 something. So 1.65 liters they need. I can approximate to 1.7 liters of urine they need. Which means what I have given is 1 liter of the solution, but how much I'm excreting, how much urine I'm passing to excrete that 513 milliequivalents from that 1 liter of the solution is 1.7 liters, which means I'm actually having a negative balance of 700 ml, which is excreted in excess. This excess water is getting excreted because I've given 513 milliequivalents in just 1 liter of the solution. Okay. Now you know the formula that exchangeable cations, that is nothing but the sodium, is equal to total body water multiplied by serum sodium. So exchangeable cations in this patient will be 30 multiplied by 110 is equal to 3300 milliequivalents. This is the total cation, total sodium in the body, total body sodium or total exchangeable cation. Now the same formula I can apply in a different way. Now the new exchangeable cations, which will not change in an SADH. I'm doing it after this 1 liter of 3% NaCl. I'm again finding this formula. Here the exchangeable cations will not change because the total body sodium must be normal in SADH, which means exchangeable cations are not going to change. And the total body sodium is not going to change. Here the total body water has now changed because if I take the new total body water after 1 liter of 3% NaCl, previously it was 30 liters minus you have already lost 700 ml, that is 0.7 liters, will be equal to 29.3 liters, which means this is the new total body water after this 1 liter of 3% NaCl. So here the exchangeable cations will be the new total body water, that is 29.3 liters multiplied by serum sodium, that is a new serum sodium, which is also going to change. Now the exchangeable cations will be same 3300, there won't be any change, then only they will be euvolemic. There is no net gain or net loss of sodium from the system. Will be equal to 29.3 liters multiplied by new serum sodium. That's a new serum sodium that is predicted, which will be equal to 3300 by 29.3. That will be the new serum sodium, which means new serum sodium will be 113 milliequivalents per liter. This is the new serum sodium. So this is a joke, isn't it? So you can see the serum sodium has just improved from 110 to 113, which means after 1 liter of 3% NaCl in a patient with SADH with a fixed urine osmolarity of 308, the serum sodium change is only 3 milliequivalents per liter rise. You are seeing 110 to 113. But these formulas have predicted something different. According to the second formula which we have discussed, they have predicted a rise in serum sodium by 13 units, that is 110 to 123. And the third formula has predicted a rise of 17 units from 110 to 127. But actually what is happening is from 110 to just 113, which means what I am trying to tell is these formulas are not going to predict the magnitude of the serum sodium change in vivo inside the body. They can give you a direction, but they cannot give you the destination. So to know the destination, you have to frequently monitor the direction. That is why I am telling you have to frequently monitor the serum sodium. That is what is going to give you the ultimate pathway regarding where you are going. Not these predictive formulas. Predictive formulas can tell you a like overall direction in what way you might be going, but they are not the gold standard. Gold standard is always frequently check the serum sodium and determine and change your treatment as per your needs. That's what the goal is finally. And with this, I am finishing off this topic on hyponatremia. Hope this is enjoyable and very easy as well. So it's all needs a little bit of common sense, that's all. And in the next section, we'll be discussing on hypernatremia.